Well, it's a pleasure to be here. And I really want to thank the organizer for giving us the opportunity to present on prenatal screening. It's nice to be able to come to the communities and sort of make you aware and talk about what's new in screening for Down syndrome. And before I lose your attention, maybe I want to give you my first message is that, in fact, prenatal screening for Down syndrome is not something that is really limited to family physicians who do obstetrical care. And our biggest problem in implementing prenatal screening in BC that we've realized is that, in fact, we have moved to first trimester screening, or first trimester combined with second trimester. And so our biggest challenge has been to reach family physicians who are really looking after these patients before transfer care to family physicians who do obstetrical care. Traditionally, family physicians who do obstetrical care go to the obstetrical meetings, and really we're trying to reach the family physicians who see the patients in the first trimester. So hopefully this you'll see relevance to this talk for your actual day-to-day practice. So I do want to make it very practical. I've been asked to talk about the how and when and to whom. So really that's really the focus of my talk. But before I talk about that, I thought I would review what the options are and why these options are, sort of are the ones we follow now. And for those of you who actually know a lot about prenatal screening already, I thought, well, they have to get something out of my talk. So I'm going to finish after talking about the hows, and I want a little bit at the end on what's coming up, what's in the horizon, what's so exciting, and where are we moving, so that all of you will sort of get something out of this talk. So the principle behind being able to screen for Down syndrome is that, over 20 years ago, individuals or physicians were screening for neural tube defect, and they recognized that we were doing that by measuring alpha-fetoprotein, which was high in pregnancies with a neural tube. And some clever person noticed in looking at outcomes that, in fact, the pregnancies that had low AFPs had way more Downs than expected. And that became like the beginning of the history on screening for Down syndrome. It was recognized that there are analytes that have a different distribution between Down syndrome pregnancies and normal pregnancies, so that if you look at the pattern of now we have 5 analytes, you'll see that in pregnancies with Down syndrome, some of those analytes are lower, some of the analytes are higher, and so that if you measure as many analytes as possible that are predictive, and they all point towards Down syndrome, your risk of Down syndrome is significantly increased. If you only have one that points towards Down and the other one are very normal, it's probably a false positive. We recognize that one of the big determinant of risk is age, maternal age. So we cannot ignore that. So that is factored into the risk calculation. But age alone is not a very good predictor. It's not a good screening test. Just think about it. Right now in BC, we have over 20% of our births that are in women that are 35 or older. So just saying, oh, you're Mrs. So-and-so and you're 36, oh, your risk is higher, we're going to send you to an amnio, would send 20% of our births now to amniocentesis. It is not a good way to screen. One has to combine age, which gives them their prior risk, with things that we can measure in this pregnancy that reflects this fetus, this placenta, to come up with the best estimate of risk. And when you offer screening to your patient, if they choose screening, that's what we're doing. We're using their prior risk, which is their age risk. We're factoring in as many markers as possible, and we're coming up with, in this pregnancy, this is the best estimate of your risk. Most of our markers, which I had in the previous slides, are blood markers. And in BC, we chose to go a screening route which is highly blood-based. And the reason for doing that is then it's accessible to all. People can go to any local lab and the blood gets shipped to Vancouver, as opposed to the challenge of introducing an ultrasound marker, which requires highly skilled sonographers. It requires that sonographers do at least 50 a year to maintain their competence. And also, which is really the biggest issue, it's competing for a resource that's already limited. Family physicians and obstetricians in smaller communities are telling us it's hard to even get a detailed ultrasound at the right time. if we start doing a lot of first trimester NT ultrasound, we're competing for the same sort of ultrasound resources. So nuchal translucency is measuring that sort of area of darkness there because it's fluid in the back of the neck. It's a very, very powerful marker, but it has to be done properly. So given the fact that we have blood markers and we have the NT, we can combine that to have different screening options. So the patient who shows up in the second trimester, she gets one blood test which measures 4 analytes because the NT ultrasound is a first trimester measurement done between 10 and 13 weeks, 6 days. But the patient who shows up in the first trimester and is informed about screening in the first trimester, she can go for 2 blood tests, and then she gets 5 analytes measured, which is a better test than the quad test in the second trimester. And finally, those who qualify will get the NT ultrasound plus the 2 blood test. So essentially, the bottom line is the more markers you test, the better the accuracy of the testing. And essentially, the better the accuracy, because even though we can set the screening test to have all the same detection rate, all around sort of 85 to 90%, what you can see is the false positive rate decreases when you do more markers. And a false positive means that, you're telling your patient she's got a positive screen, she's anxious, she needs another test if she wants to have the definite answer. So we do want to reduce our false positive as much as possible. And it's in that context that we consider IPS, which is the one that has the NT ultrasound combined, better than the 2 blood tests, which is better than the single blood test. Now, I do want to point out that there is another form of screening, which is first trimester screening. So that's having just 1 blood test and the NT ultrasound. It is not funded by the public system because to be able to do good first trimester screening, you have to do NT ultrasound and other ultrasound measurements. And we couldn't go the route of a first trimester screen that was highly ultrasound dependent when we knew we had limited ultrasound resources. I did want to point it out, though, because it is available privately. It is available in Victoria. So some of your patients may be aware of that. And the point I want to make is that, in fact, the detection rate for Down syndrome is very equivalent. So what the patient gets for her $525, in my mind, is not a test that's more accurate. She's paying for having earlier results. And for some patients, that is worth the money. They want to be able to go in around 12, 13 weeks and have an answer to their screen as opposed to being waiting till 16 weeks, 17 weeks before they do the publicly funded screening. So how do we do it? Essentially, I've already mentioned it. For sort of most women, it's a serum-based test, but it's 2 blood tests with a result that's issued only after the second one. 1 blood test in the first trimester, 1 blood test in the second trimester. Some women qualify for IPS, and I'll tell you who in a minute. They get the NT ultrasound in the first trimester. Those who miss out on the first trimester screening can still have the quad test, which is 1 blood test in the second trimester. So the message here is if you look at the window, it's, the first blood test or the ultrasound is 11 to 13 weeks, 6 days for the ultrasound. It's 9 to 13 weeks, 6 days for the blood test. So unfortunately, there's a significant proportion of women in BC who are still not having integrated screening because they're missing out on that first trimester test. We're hoping to reduce that number to only about a quarter of the pregnant population who want screening, but at the moment, in some health authorities, we're still at 40%. Vancouver Island actually is in that sort of 25 to 30%, so you've done very well on the island in getting patients who want screening into screening early on. I've already mentioned the sites for NT. So which test to which women? Essentially, as I've already pointed out to you before, the detection rate is fairly similar for the different tests in the different age group. And the detection rate, a point that's important to note is if you start as a prior risk that's high because you're older, in fact, the test will offer you the best detection. So the 35 or more actually have a very good detection rate with our test. The less than 35, because they start with a low risk, it's hard for these analytes to bring them up all the way to a positive test, and so our detection rate is not as high in the less than 35. What's the most different, though, for each group I've mentioned already is the false positive rate. And so if we have limited NT resources, we have limited ultrasound resources, we've decided to invest them for the women for whom the test will have the greatest impact. And as you can see, the 35 and more, so the 35, 39, or 40 and greater, in terms of false positive rate, they're the one who really benefit from having an NT ultrasound added to the blood work. Because see, you go from sort of 20% down in terms of false positive rate, whereas in the less than 35, the numbers are not that different. And this is why the women who have the NT plus the 2 blood tests are the older women. So the women that are 35 years old or older, the women who've had a Down syndrome or another trisomy in the past, women who conceive their pregnancy using IVF and ICSI, and ICSI stands for intracytoplasmic sperm injection. That procedure actually does increase their risk of having a baby with a chromosomal abnormality, so we consider them at higher risk. And so they also benefit from having that sort of NT added to the blood tests. The reason we are offering that test also to the women who are HIV positive is that there is a risk to the fetus if you do an amnio on an HIV positive mother of actually transmitting the HIV virus to the fetus. So in HIV positive pregnant women, we want to minimize invasive procedures. So we say, okay, there's not that many in BC. Let's offer them, if they're interested, the best screening test, which has the lowest false positive rate. And that's an issue of, not that they're at higher risk, but we're trying to prevent an amnio in these women as much as we can. And all twin pregnancies, we should do NT ultrasound in addition to the blood test. And the reason for that is the blood test is like the analytes that come from placenta or one placenta and 2 babies. And so we know that if there's 2 placentas, they may be dizygotic, they may be non-identical twins. So if you have one that's got Downs and the other one is normal, what you measure in the blood is really a mix of the two. As opposed to when you do the NT ultrasound, you're assessing each baby individually. So it's actually a better screen, and it's an important part of the screen of multiple gestation is to do the NT ultrasound. So that's why, regardless of their age, if they have a twin gestation, they should have an NT ultrasound if they want screening altogether. And then everybody else, so your singleton, less than 35, so most of our pregnant women, what is offered to them is just the 2 blood tests combined to give one calculated risk. A few practical points. Each analyte varies greatly by gestational age. So the calculation of risk is totally dependent on what you measure and where is it in terms of multiple of the median for that gestational age. So gestational age dating is very, very important. If a patient does not have regular cycles and is unsure of her LMP, she needs a dating ultrasound before she should participate in serum screening, because her results will not be easily interpreted or accurate if we don't know how pregnant she is when she does her screening. If a patient has regular cycles, knows her LMP, she does not need a dating ultrasound to get sort of serum screening. If when she does have a dating ultrasound, someone recognizes that the pregnancy was wrongly dated, we should recalculate her screening estimate. Okay, so if the report you get for screening is based on LMP only, and then she gets her detailed ultrasound, and you're redating her pregnancy, you should call the lab and have them recalculate the risk, because that risk was not calculated using the right gestational age. Okay? So that's an important point, because it's one of the reasons for false positives. One tool that you may not be familiar with, but since I wanted to be practical, on our website, which is bcprenatalscreening.ca, there is actually a nice little dating tool right on the first page, which your MOAs could learn to use. So you could use, your nurse can send your patients. And essentially, they just put in there their age, their last menstrual period or their ultrasound information if they have it. And then if they're singleton or twins. And then it tells them when they should have their first, it gives them a calendar of when they can have their first blood test, when they can have their second blood test, when their NT ultrasound, if they qualify, should be booked. So I think it's a useful tool for your whoever helps you arrange testing for your patients. And this is actually the homepage of the website, and there's an entire section for patients and their partners. And so if you want, I know there's a lot of issues to talk about when counseling patients about whether or not they want screening, but if you want them to be a little bit prepared before they do have that discussion with you, it is useful to send them to the website. There's patient pamphlet. You have an example. And in fact, I brought hundreds. So you're welcome to take more and bring them to your office if you want, and you can order more. We will ship them to your office. I brought them in English, but we have them in Punjabi, we have them in Chinese, we have them in French. So I think, and for those patients who don't want to read but want to watch a video, there is a video on the website. And I think all of this really sort of helps sort of have that session that you'll have to have with them to see whether or not screening is the right choice for them. Really, they have to understand that it's just a screening test. It's not going to give them a definite answer. It's just going to tell them if they're at higher risk or lower risk. And if they're a positive screen, it is an invasive procedure that they need to have to get a definite answer. And I think it's important for them to know that there's even risk associated with that procedure, so that if they start the screening process, they have already kind of decided, okay, what will I do with the next step, and why am I doing it, and does it really make a difference to me at the end? Our uptake of screening in British Columbia is about 55%, just to give you sort of a rough idea. It is higher in the older mothers, who I think consider themselves at higher risk. But overall, it's about 55%. And we don't have a higher target than that for our population, because I think it's very dependent on patients themselves. This is a visual aid that I don't know if you use, but I also have some in the back. I think it's an important tool to try to get the patients to understand what a screening test is. But if they are a positive screen, their risk of Down syndrome is truly the risk that's written on the report. We've actually looked at our outcome data, and it's very much within that ballpark figure. If they're given a risk of 1 in 10, that's the risk that the pregnancy will have Down syndrome. If they're given a risk of 1 in 200, that's the kind of magnitude of risk for that pregnancy. So this is the patient pamphlet, which they really sort of makes them go through all of these issues ahead, and might really help them decide, is screening for me? Do I really want to go into this point? Because to be honest with you, we do recognize that if a patient would not go and have an amnio for her positive screen, we may significantly increase her level of anxiety, from having a positive screening, carrying that risk all the way to the end. If a patient says, no, I really want to know, and if I've got a significant risk, I will go ahead and have an invasive procedure, then that's the person who may really benefit from screening. We were surprised, but we do have outcome data, and when we look at all women who have a positive screen, we only have 50% uptake of amniocentesis. So there's a lot of women who are positive screens who choose not to have amnio, and whether or not those women regret having had screening to start with and should have made the decision against screening to start with is what we're not sure. So briefly, I do want to let you know what's happening in the horizon, because I think it will greatly change the face of screening, and not in the so distant future. So what's very interesting is that if we take blood from pregnant patient in the maternal circulation, there is actually genetic material that does come from the placenta and the baby. Okay? There's very, very rare cells, but these cells do traffic from the placenta to the mother, and these cells are destroyed. And in that destruction of the cell, it releases the genetic material. So it releases the DNA. So that in fact, if I take blood from a pregnant patient and I isolate the plasma, in that plasma, I will find mainly her DNA that comes from her cells that have released it, but I will also find some fetal DNA. About 5 to 10% of the DNA will be fetal. And if I'm just looking for Y, so male genetic material, that's easy because it's different from the mother. She doesn't have any Y sequences. The challenge is how can I actually find, sort of use that genetic information that comes from the baby when it's a trisomy 21 or Down syndrome, knowing that really the baby with Down syndrome has just the normal genetic material, it just has more of the chromosome 21. So for the longest time, we didn't think we were going to be able to do that because the baby's genetic material is really more or less the same as the mother's, and it's got a little bit more of chromosome 21, but his or her chromosome 21 doesn't look any different. And really what's happened over the last sort of 3 years, and the field is moving very, very quickly because in the States, prenatal screening is billions of dollars business. And so industry, as opposed to academic laboratories, have invested a huge amount in trying to come up with a better screening test that will have almost no false positive and will have almost 100% detection rate of Down syndrome. And it's kind of all these competing industries that have really moved the technology very, very quickly. And the bottom line is that if the pregnant patient is carrying a normal pregnancy, so I told you it was about 10% of the DNA was from the fetus. So I've just represented like the contribution of 10 cells. So in the normal, that cell has just normal amount of chromosome 21 material. But if the pregnant patient is carrying a baby with Down syndrome, that one contribution, that one cell out of 10, contributes more chromosome 21 material. And so this technology that has been developed to sequence everybody's genome, you've heard about, you can have your genome sequenced for $5,000 and know all of your genetic variants. Well, that same technology is essentially, it's machines that have the power to just sequence DNA at very, very, very high throughput. And this technology has been transferred to the field of Down syndrome testing by saying, okay, if I can sequence genome, if I can sequence DNA, I'll take DNA from maternal plasma. Even if there's not a lot, I will just sequence it all. And I will let the computer tell me how much of this sequence belongs to chromosome 21 versus the other chromosome. And if the pregnancy has Down syndrome, I'm going to find more from 21 than I would expect. That's the basic nature of it. You just count the reads and see if you have more reads than expected. It's still expensive technology, but the price is coming down drastically. And these are the kinds, there's actually a large number of trials that have been run by industry. And we're getting over 99% detection rate of Down syndrome for like 0.2% false positive rate. That means that of all pregnant patients, if we offered this test, only 0.2 or let's say 0.5% would screen positive, as opposed to our current 5 to 10 to 15, 20% false positive depending on age. So this is very powerful technology, and it is going to come at some point. It's just a question of cost and how quickly can this kind of technology be implemented in laboratories in Canada, because it is very sophisticated technology. So my key messages before I open it for question is that, prenatal screening is a woman's choice. I think it's a very complex issue, and it does take a lot of your time to counsel these patients as to whether or not it's the right thing for them. We recognize that, and we hope that the resources that are available on our website and that we're happy to ship to you might help in that discussion. Best screening starts in the first trimester. And one of our problem is that sometimes the testing isn't offered till patients are transferred from family physicians who don't do obstetrics to family physicians who do obstetrics, and they kind of fall between the crack there. And it is a very dynamic field, and I think that there will be better options and more promising options coming in the very near future. So I'd love to have your questions and comments and see how we can help sort of help you provide the care to your patient.